actually will. There's someone that's moving my slides over there. Thank you. The amount of new data is making this subject basically a moving target. And I have always the impression that we are maybe trying to fish from a railway bridge, as Handicap is doing here, when we look for targets to treat ischemic MR and functional MR at large. And just to remind ourselves, we all remember the mechanism has been described by Robert Levine's group of the apical tethering of the leaflets causing MR, and this apical tethering is due to the pull of the mitral valve by the remodeling ventricle, either a regional remodeling or a global remodeling, as in functional MR. This actually exacerbates the cascade that's already in action in these patients that causes myocardial remodeling. This cascade involves the reducing of cell contraction and the inducing of apoptosis, which are all both due to increased wall stress. But increased wall stress, and I want to point this out early on, also causes extracellular matrix remodeling. And an extracellular matrix actually has not been traditionally a target of treatment in these patients. All of these are exacerbated by a general all-body neurohumoral activation, which actually activates many of these pathways. Just to also remind ourselves, this is the model that we've been working on for several years now, basically trying to separate the elements of remodeling the MI and the mitral regurgitation based on using a shunt, a Teflon shunt between the left ventricle and the left atrial appendage, as you can see here, causing a steady flow of mitral regurgitation, which is admittedly a moderate mitral regurgitation. And in our first work, we actually demonstrated that adding mitral regurgitation to a myocardial infarction causes excess remodeling. It may be intuitive, but it was never demonstrated, and so we can see that we have increases in end-diastolic volume, but more importantly, in end-systolic volumes in those animals that have had mitral regurgitation in addition to a myocardial infarction, and this also translates into a reduction in contractility as demonstrated by the preload recruitable stroke work measured using a conductance catheter. Looking at the biochemical side of remodeling, and I'm sorry to cause you a headache so early in the morning, but there will be some basic science here. You can see that there is a reduction in the animals that had mitral regurgitation in pathways that are connected with hypertrophy and are opposed to cell death, to apoptosis. For example, the pathways starting with the GP130 containing receptor, the pathways that are centered on AKT or protein kinase B, which is a central protein that is pro-hypertrophic and anti-apoptotic in the cell, and no reduction whatsoever in the activation of caspase-3, which is a key enzyme causing apoptosis or cell death. So what we see net here is a drive in those animals that had MR towards apoptosis against hypertrophy, and of course with all that, what it entails in terms of prognosis. Looking at the extracellular matrix in that time, we've seen in these animals that have had mitral regurgitation a more pronounced activation, both of the enzymes that are causing matrix degradation, but more so of these enzymes like tissue inhibitor of matrix metalloproteinase 4 that are causing matrix stabilization, meaning more fibrosis. Now, our current approach for treating those patients is repairing the mitral valve, and it was very easy to do in our model. So what we did, basically, we tied off the shunt, we imitated mitral valve repair, and we saw that in those animals that have had repair, reverse remodeling occurred, and as you can see here in the black columns, and the volumes were reduced, and this also translated into better contractility, actually quite similar to those animals that have had only myocardial infarction, but of course significantly different in those animals in which we left the mitral regurgitation open. So early repair of mitral regurgitation causes reverse remodeling morphologically, and this also is translated into the changes on the biochemical level. As you can see here, the same GP130 that we were looking at before, and these now the gray columns are those animals left with MR, and the white columns are those in which the mitral valve was so-called repair. You can see that there is basically even an overactivation of those pro-hypertrophic, those quote-unquote good pathways that are related to survival, and this translates also into reduced tone of apoptosis in those animals. Looking at the extracellular matrix again, we can see that in those animals in which we add mitral valve repair, the activation, the pronounced activation of the tissue stabilization or the extracellular matrix stabilization enzyme like TIM4 that we've seen in the previous experiments are reduced as opposed to the animals that had MR left. So the drive to stabilization of fibrosis is reduced. Now we looked at ways to intervene in this process, and as you've seen in the first experiment, we've demonstrated that a protein that is related to cell contractility, or basically to calcium cycling in the cell, the sarcoplasmic reticulum calcium ATPase, or SERCA2, was downregulated in those animals that have undergone the remodeling process. So we hypothesized, together with our collaborator and dear friend Dr. Roger Hajar from Mount Sinai Hospital in New York, that maybe upregulating SERCA using a gene therapy approach would be beneficial in those animals. So we took the same model, the 3-month model, and we gave the animals a gene encoding for SERCA using a vector-based, a viral vector-based approach using adeno-associated virus. And as you can see, in those animals in which SERCA2 was upregulated, the contractility was preserved, as manifested again by preloaded recruitable stroke work and DPDT. The left ventricular ejection fraction was actually not dissimilar when using the repeated measures ANOVA during the test, and their volumes were reduced in those animals. So we looked also at the biochemical levels in those animals in which SERCA2 was upregulated. We can see that the AKT pathways remains upregulated. STAT3, which is downstream of the GP130 that I was showing you before, is also upregulated, and the caspase-3 remains non-significantly different, meaning that we have an increased drive of anti-remodeling in these animals, and SERCA2 might be beneficial, in this case, when given early in those animals, basically with reperfusion, which opens up all kinds of questions. Should we give such a therapy when we see those patients first at primary PCI, for example? Now, the most common situation actually, or unfortunately, is those patients are arriving to mitral valve repair late in the process, when already the ventricular remodeling is well established, and unfortunately, many times, the reverse remodeling that we may expect at the ventricular level does not occur, or occur in a very disappointing fashion. So we actually try to imitate this situation by performing a late repair in those sheep, and in the sheep we took a 5 months delay as opposed to the 3 months that we use in the basic experiments, and we've shown here that these animals, when sacrificed, demonstrated no significant benefit of the late repair. The repair was performed at 3 months. The late repair as opposed to the animals that did not undergo repair at all. So late repair with delays that are appropriate to sheep did not demonstrate reverse remodeling, enhancing once again the need to intervene in those patients very early in the disease process. Of course, the same manifested itself in the molecular pathways that we've examined, here AKT and STAT3. You see that there are no differences almost between the two groups. So, now the question the question is obvious. Does gene therapy with SERCA2A, like we did in the non-repaired animal, would be beneficial in improving the results of late repair of mitral regurgitation, as we said, the most common clinical situation? So we gave those animals the SERCA2 and we repaired lately, like we did in the first experiment, after 3 months, and we compared again the volumes and the contractility. And as you can see, that those animals in which we had both repair and SERCA delivery at preservation of left ventricular function as manifested by the preload recruitable stroke work. almost no difference between the first time point and the sacrifice time point. As you look at end-systolic volume, admittedly another surrogate of global left ventricular function, you can see that the smaller volumes at all 3 time points were seen in those animals that received CIRCA and have undergone mitral valve repair in parallel. So the combination of mitral valve repair and CIRCA2 upregulation conferred an extra benefit in terms of remodeling beyond what would have been achieved by mitral valve repair alone. So up to now, we've dealt with the ventricle, and most specifically with the cardiomyocyte. But the cardiomyocyte is actually a very small component of the muscle. Most of it is made of connective tissue. And the connective tissue, we know, remodels as well when the remodeling process occurs. As you can see here, there is a very tight connection between fibroblasts, marked in green, and the cardiomyocyte, which you can see in red. So the interplay between these cells is occurring at multiple levels, but one of the main players in this field is TGF-beta. TGF-beta is a cytokine that mediates cardiomyocyte hypertrophy, that maybe induces the cardiomyocyte to produce by itself profibrotic mediators, but definitely induces the fibroblast to undergo myofibroblast transformation. A myofibroblast is a cell that produces extracellular matrix actively, and so we presumed that TGF-beta as a central player in this profibrotic process is maybe an actor that we should target in order to reduce remodeling. Roger Hajar's group have stumbled upon a molecule called CCN5, which is a member of a family of, actually a relatively newly described family of cytokines which are acting on the connective tissue as a group and are very, very important in cancer and metastasis. But the CCN2, which is also called connective tissue growth factor, is very central in activating TGF-beta and promoting fibrosis. CCN5, on the other hand, which is a shortened version of CCN2, actually acts the opposite way and inhibits the activation of connective tissue growth factor and inhibits its action on TGF-beta. And on an experiment that Dr. Hajar's group has performed on mice, in which aortic ligation model was induced, you can see that the animals which received CCN5 have smaller volumes and better contractility as compared with the animals that actually were given an empty vector as a control. So we're asking ourselves the same question, and these are preliminary results, first shown here, that we use the same sheep model of inferior mice, and in this model we've analyzed very carefully the animals also using MRI, specifically using 2 techniques in MRI, both T2 mapping and late gadolinium enhancement, to demonstrate fibrosis and to measure the extracellular volumes. And what you can see here, that in those animals that were delivered CCN5, the border zone fibrosis was reduced significantly. The remote zone extracellular volume fraction was reduced significantly, and the contractility as measured by conductance catheter was significantly improved. And you can see here also histologically in Masson trichrome and picroserous red staining that the area of fibrosis was significantly reduced in the animal that received CCN5, and this is in sheep, not in mice. So this is one target, and the target is demanding a solution, and we are now looking at targeting those 2 areas, the myocyte remodeling and the extracellular matrix, in order to maybe improve our results in inhibiting remodeling. But it has come out actually that not only the ventricle remodels. As you can see here from a work from Miguel Chaput from our group, we can see that as remodeling progresses, the leaflet area also increases. And actually anyone that reads echo can see that those valves, although known not to be the culprit in this situation, are themselves thickened. They don't look like normal valves. And when you measure the area, those valves are actually a much larger area than normal valves. And you can see that the closure area actually does not increase very significantly in those in animals that have MR. And actually, one hint to the solution to this conundrum was provided by Baudouin from our group. This work was led by Ehud Schwamenthal from Tel HaShomer. And you can see here that in patients that have aortic regurgitation, the ventricle also remodels, enlarges. The annular area in these patients enlarges as well. So why not too many patients that have aortic regurgitation have also mitral regurgitation, functional mitral regurgitation? And the reason is suggested by the results of this study. You can see here these are plotted on one area, the leaflet area, and on the x-axis the end diastolic volume, and you can see there is a perfect correlation between the leaflet area and the end diastolic volume in the patients that had aortic regurgitation. But in the patients that have functional mitral regurgitation from other causes, you can see that the correlation is far from perfect. So maybe the adaptation of the leaflets is not ideal, and this is the reason why those patients have functional mitral regurgitation given a similar end diastolic volume. And this is a work, again, done by Miguel Chaput on patients, this time, that have functional mitral regurgitation, measuring leaflet area and the closure area. And you can see that if you take the patients that have global remodeling and have functional mitral regurgitation, the ratio between leaflet area and closure area is much smaller in those patients that have functional MR as compared to the patients that do not have functional MR. So this suggests that the compensation of the amount of tethering, which is performed by remodeling of the valve, and we know now from other studies that the biochemical changes in the valve actually reflect the biochemical changes happening in the extracellular matrix of the ventricle itself, maybe those changes can be adaptive if the valve grows enough to compensate for the tethering. But in those patients that do develop functional mitral regurgitation, the compensation is reduced, and thus they have mitral regurgitation, which actually initiates the vicious cycle that we talked about and perpetuates and aggravates remodeling. So in summary, ischemic MR drives an excess remodeling process in the left ventricle, both of the cardiomyocytes and in the extracellular matrix. This process can be retarded by early repair of mitral regurgitation. This remodeling process may be modulated by upregulating relevant molecular processes using a gene therapy approach. And the remodeling process involves also the valve's leaflets, which can also be maladaptively remodeled, exacerbating functional mitral regurgitation. And what actually this tells us, and we should always, in this case, because it's a multifactorial issue, think outside of the box, look everywhere for solutions and not only under the lamppost. And I hope that in the coming years, which sound to be very exciting in this field, we'll have maybe a solution to treat both the ventricle and the valve, which are both acting hand in hand to induce this situation that causes much morbidity. So in thanking those who gave us funding, I want to thank both the Adassa team and the Mass General team, and of course my mentor sitting here in the first row, Dr. Robert Levine, without which all of this data would not be available to us. So thank you very much.